Thank you very much, Dr. Mayer. This has been a long day for all of us, and it has been with a lot of energy. And just sitting around all day, I have been thinking about what brings this energy, and I think it is primarily two things. One is that we are all here with a common mindset. The mindset that we do what is the best for our patients, and this, regardless of politics or specific interests. The second is that we are sort of, I was thinking of the words of Keats, we're standing upon the forehead of the age to come. So we've seen great developments. We are awaiting many more to come. And this is an era of enlightenment that comes in contradiction with a long period of darkness. And this was a time that even somebody as great as John Hewlings-Jackson would say that he who is treating by drugs hemiplegia owing to softening or a clot is treating a hole of the brain. And if we had drugs which could dissipate the plug in the vessel, I know of none, they would have to do it with marvelous quickness, or the nerve tissue would be dead by starvation before circulation was reestablished. And here we are. We have the drugs, we have the devices, the methods, and what we have been talking all day is how to get that marvelous quickness. And this is part of what quality is about. So interestingly, about a year after John Hewlings-Jackson died, Richard Stuart Stevens was born. And Richard Stevens had a relatively conventional career. He started as a cardiologist, he did geriatrics, until in his retirement, his wife died of a stroke, and then he decided to dedicate the last 15 years of his life to improving the outcomes of stroke patients. So he was the first one to conduct a well-designed, randomized controlled trial about stroke unit care. And he was also the first one to understand that each one of us needs to study the incidence and outcomes of stroke in the community that we live in. So he was the first one to design and conduct a stroke registry. And I would like to make the following points. One is that quality presupposes effective treatment. If we do not have effective treatment, we cannot have quality efforts. But effective treatment is a moving target. Each time there is another layer of new treatment superimposed on the previous one. So at any given time, quality involves setting standards, the best science and the best practice, as Dr. Yauk said, and then implementing the standards and finally maintaining them, because sometimes it's easy to implement but difficult to maintain. And if we are to sort of divide the course of human civilization by the breakthroughs of stroke care, we start from the beginning to the mid-1980s, where there was nothing, maybe heparin or endarterectomy 2 months after the stroke. And then from the mid-1980s, as we said, to 1996, we have the stroke unit care era. 1996 to 2015, IV TPA, and initially 3 hours, and then 4.5 hours after 2008. And then 2015, we see the Fab5 trials that Dr. Mayer mentioned. And this is the early endovascular thrombectomy era. Why is it early? Because it's only 6 hours. Now we have the DAWN trial results, and hopefully in January in the stroke conference, we will have the DIFFUSE-3 trial results, where we will have the era of late image-based endovascular thrombectomy up to 24 hours. And maybe the next one is just wishful thinking, but in a few years, after the eyewitness trial comes out, the ECAS4 Extend consortium from Germany and Australia come out with their trial, then maybe we will have the late image-based IV TPA. So lots of exciting things to come in stroke research and subsequently quality. So we're going to talk about these 3 proven treatments for stroke: stroke unit care, IV thrombolysis, and thrombectomy. And even though we saw that thrombectomy is a new exciting development with a number needed to treat less than 3, when we talk about all stroke patients, the impact on stroke outcomes comes primarily from stroke unit care. So going through those 3 points, which also reflect the course that we have taken as a comprehensive stroke center over the last 20 years, we have been trying to treat our patients well in the stroke unit. And this typically means preventing blood clots, putting them on oral antiplatelets, oral anticoagulants, statins, educating them, assessing them for rehabilitation. But there is a lot of other intangible measures, control of blood pressure, control of hyperglycemia, as Dr. Varela said, early nutrition assessment with dysphagia screens, early IV hydration, lots of things that we do in a stroke unit or now in the critical care setting that cannot be done in the general floor. And one of the great projects that has happened over the last few years nationally is the Get With The Guidelines project for the American Heart Association. We have been participating in it for the last 10 years, and the time is not enough to show all the measures. Certainly, everybody in this hospital has played a great effort into getting our numbers up and our quality improvement projects running. But in this defect-free composite stroke measure, we have been getting consistently up over the last few years. This is a chart that was made with the help of Don Scozzari, our informaticist, so we thank very much. And that was stroke unit care. Second is IV TPA. As you have heard, we were the coordinating center and the imaging center for the NANDS trial that established TPA within 3 hours. So together with IV TPA came a new number of quality metrics. The goal now is to treat people as fast as possible, as many people as possible, and also as well as possible, because we know that protocol violations are well associated with intracranial hemorrhage. So we measure door to needle time, door to labs, door to CT. And at the same time, we have been trying to improve our within the walls efforts of what makes systems and processes faster. Is it parallel processing? Is it EMS pre-notification? A great number of things that were said earlier on. And nationally, the same has been done with the Target Stroke project with Dr. Yaruk, phase 1 and 2. Phase 1 started in 2010, and it resulted in a significant improvement in increase in the number of hospitals that give TPA with door to needle less than 60 minutes. And now we participate in the phase 2, which tries to bring the time down to 45 minutes. We have been increasing the number of patients that get TPA within 4.5 hours. And this is not easy. It has required a lot of team effort, brainstorming, quality improvement projects. Over the years, we're proud to say that we have been increasing decreasing our door to needle time so that a great number of patients get it within 60 minutes. And now that we started participating in the phase 2, already our median time is below 45 minutes, our door to needle time for IV patients. So now we go to the third aspect of quality efforts, endovascular thrombectomy. We saw the 5 trials that established endovascular thrombectomy. And with them, we now have another whole set of measures. So how can we make that process faster? We have to break the time of onset to recanalization to a number of other times. So onset to door of the emergency department, emergency door to picture, or CTA now, picture to puncture, puncture to first pass to recanalization. And each one is a target for quality efforts. We're doing excellently at that, and we have more quality projects coming up in the very near future. The establishment of endovascular thrombectomy not only increased the complexity of our efforts within the hospital, but also the quality that is needed in the inter-hospital transfer and development of regional care systems. So when we had the IV TPA only, it was a relatively homogeneous population of stroke centers that could give IV TPA and provide stroke unit care. Now, we have tiers of care. We have the acute stroke-ready centers. And for example, in our system, we have 3 freestanding emergency departments that are essentially stroke-ready centers that give the TPA and then transfer the patient. We have the primary stroke centers that can give the IVTPA and provide stroke care. And the advanced comprehensive stroke centers, as we have been for almost the last 2 years, that can provide care with IV, endovascular, but also hemorrhages. Now we are seeing the development of the concept of thrombectomy-capable stroke centers that provide the whole ischemic stroke care, including thrombectomy, but excluding hemorrhages. And also we have now the different approaches. Does the patient with the large vessel occlusion stroke go to the primary center, get the IVTPA, and from there to the comprehensive, which means that he or she will get faster IV, but maybe a little bit later endovascular treatment, or do they go directly to the mothership, the comprehensive stroke center? And it appears that we may have to rely on geospatial information, advanced software, so that we can develop a policy for each individual region. So one significant concept is the DDoR, as Dr. Yauk said, the door in, door out. But depending on that, we have to make quality decisions and quality improvement projects as to whether patients will go directly to the comprehensive or will go first to the primary stroke center. We have seen a significant increase in the volume, so we have to be very fast and very efficient about how we improve those things. So overall, we have seen a movement of the pendulum towards comprehensive stroke centers over the last few years. We suspect that once late image-based endovascular thrombectomy is going also to be announced and established, this will require new quality efforts and will further move towards comprehensive stroke centers. But if, and this is a projection, if and when late IVTPA implemented, then this will take things back to the primary stroke center. So instead of doing the scoop and run approach of trauma, to do sort of a scan and plan approach, especially for late appearing patients. And this is all quality for acute treatment. We are happy these days if we have a good outcome in 40, 60% of patients. The question is what happens to the other half of patients. And we do not have much research or much quality efforts yet on recovery and rehabilitation. I suspect that this will be the next and final frontier of stroke treatment, and Dr. Howell will speak about that. Thank you very much.